Welcome to Your Healthcare Matters. I'm your host, Jenna Sims, and I've worked in healthcare for over a decade. And like many of us, I'm really concerned about the deterioration of our healthcare system. On this podcast, we interview patients, healthcare professionals, and advocates to provide unique perspectives and helpful tips for navigating our failing healthcare system. My goal is to inform, connect, and inspire listeners to take your health into your own hands. My guest today is Dr. Josh Greggain, who is an acclaimed rural family physician and medical leader. He currently lives, works, and plays on the traditional territory of the Musqueam people. He lives on the UBC's Vancouver campus with his wife, daughter, and their French bulldog puppy. Since January of 2024, Dr. Greggain has served as the program director for the UBC Department of Family Medicine postgraduate program, the largest and most diverse of its kind in Canada. As a rural clinician, Dr. Greggain served as a physician in Hope and the Fraser Canyon, the territory of the Stalo and Inklaklamuk Nation, for 17 years. Since 2019, he has co-led the RCC BC network of rural divisions, and in 2023, he served as the president of Doctors of BC, playing a key role in negotiating and facilitating the LFP model for the province. Dr. Greggain, welcome to Your Healthcare Matters. Thank you so much for fitting us into your busy schedule.
Thank you very much for having me.
Great. So we'll dive right in. I'm curious to hear what initially drew you to family medicine and what has kept you passionate about this field throughout your career.
It feels like that was a long time ago now, where I was applying to medical school and sort of thinking about my future. But for me, family medicine was critically important because it was family focused. And at the time during medical school, I had 2 children of my own. And so it was really important to sort of get the breadth. But really, it was the opportunity to establish relationships with people and connect with them. Family doctors are generally the jack of all trades, the master of none. Mm-hmm. And so you get to be involved in so many things. And even in my career now, I've worked emergency medicine in the office, in the outreach clinics, internationally, across the province. And it's just been such a privilege to be involved in all those different things without feeling the pressure of having to be the expert in one particular area.
Right. I'm sure that keeps it interesting, not doing the same thing all the time as well.
Always, and even over the last few years as we do virtual care. And so yesterday I was supporting some of our First Nations communities in the north and on the coast, which I can do with my skill set, a bit of technology. And so it's never a boring day in family medicine.
Right. I'm wondering how the role of family medicine practitioners has evolved over the years and what factors you feel like have driven those changes.
And so I mentioned some of them earlier. The technology has evolved cataclysmically the last several years. And so specifically virtual care, we had started some of that back when I was working in Hope in the Fraser Canyon a little bit to try and close the geographic gaps. But the fact that now we're doing give or take 50% of our care either online or on the phone has just opened up so many more opportunities. And so the technology has been a big difference. I started in a practice that we're still using paper charts. So we still had notes, handwritten when I was first practicing. And so the opportunity for technology to evolve and give the information that I need at my fingertips. And so it used to be, if it was in your chart, you knew it. If it wasn't, you'd have a hard time finding it. And now it feels like I can, through a variety of methods, get access to information from ultrasounds and consults and pharmaceuticals that are across the province, across the country, and sometimes even places that I would never have thought of before.
Right. And how do you feel IT has sort of integrated charting? Do you feel like there are still some areas where we could be improving the communication between different types of care?
Absolutely. I think the siloing of both the geography and so particular areas across the province don't interconnect well. We're still struggling with the hospital to office interface. I have been privileged for the most part to work in rural communities where the physicians or the nurses or the nurse practitioners go back and forth to all those places. And so the information gets held in the relationship, not necessarily the chart, but we can definitely be doing a better job of integrating more information across the province. And I think that's really important when we start to look at not duplicating care, but also just like making sure that if Jenna, you were in the emergency room, that access to your information was really important for the people looking after you.
Right. So it helps with that continuity of care, especially if you're moving from different health authorities and whatnot.
even from, again, the office into the emergency room, into the maternity suite, into the long-term care facility. It's really important that information flows seamlessly to, again, get better quality care, but also better inform you as the patient and us as the physicians or providers.
Hmm. Would you be able to speak to our listeners a little bit about the LFP model, sort of what that is and how that's changed things for physicians?
Sure. And so the LFP model stands for Longitudinal Family Practice Payment Model. And so it's a way to pay physicians about how they provide their care. And so, for a bit of context, traditionally, people were paid on a fee for service. So you would come and see me, we would talk about a particular thing, I would get paid a fee to provide that service. And so that was a good. It worked for a lot of years. I think as the patients have aged, just our population has aged, have become more complex. We've engaged with much more complexity around physical and mental health conditions. That became very difficult to say, you can come and see me for a thing, we'll provide the fee for that service. And so the LFP model was a negotiated agreement between the government, the provincial government, and the doctors of BC, with support from BC Family Doctors and the Family Practice Service Committee and the um, uh, BC College of Family Physicians, alongside other health agencies, to help support the fact that we need to be paying physicians differently, because if we expect a different outcome, then we need to do that differently. And so fundamentally, the LFP model pays physicians for the time that they spend, as well as some of the interaction or things that they do. And so whether they see you in their office, or whether they put an intrauterine device in, or whether they give you a flu shot, all of that is accounted for the time that you spend. And I think fundamentally for family physician, and I hope for the patients, it's meant that people get the time that they need in the office with their physician. And so you have the opportunity, whether you're coming in with a mental health crisis or whether you're coming in with an aging parent, that you have the privilege to say, I'm going to give you the time that you need. And the feedback we've heard from my colleagues or my fellow physicians is, it takes the pressure off of feeling like you had to be on the hamster wheel all the time. It now gives me the opportunity to give attention, care, and time to the patients that I really wanted to give all along, but didn't feel I had the opportunity to do so.
Right. I mean, that sounds like it's really going to help patients feel like they have the time to talk to their doctor and go through the list of things that are bothering them. And like you mentioned, I think that's especially important for seniors who might have a whole bunch of comorbidities or different things happening, or anyone who gets white coat syndrome. That sounds like it's going to be really beneficial to not feel so rushed.
I think it's beneficial for the patients, but it's also for the physicians, right?
Mhm.
You don't feel like you have to sort of do a number of things in a day. If someone takes more time, you're not sort of watching your watch to say, "Oh gosh, I have more things to do." We know that physicians are still in high demand, and the burden of the physician is, I have more people to see, but the fact that you get to be paid for the time that you spend with absolutely some of the elders who are having multiple comorbidities, but also a young mom who's struggling with breastfeeding. Those aren't quick, here's your prescription, please leave the office, or a young individual with mental health crisis. There's a whole series of things, because that beauty of the breadth of family medicine is I can see an octogenarian and an 8-year-old in the same day. And so try to be sure that that family, those patients, those elders get the time that they need is really important. And that was one of the big drivers for the LFP model.
Right. And can you explain to us when the LFP was sort of initiated and some of the changes that you've noticed since then?
Yeah, so it's a bit of a story, if that's all right. And
Sure.
so I think through the pandemic initially, or 2020, there was a recognition we had to do things differently. And there was this great sense of like, we're going to do virtual care. We're all going to work on this together. And there was a moment, through the pandemic where patients were banging pots at nighttime to really lift up the healthcare workers. And then there came a time through 2021 and early 22 where it became apparent that this wasn't going away quickly, and that not only was the healthcare system sort of struggling, but the primary care system, or the family medicine in particular, was in a really tough place where we just didn't have enough things to be providing to patients that really needed it. There was a time where virtual care almost exclusively was good and it helped, fill the gaps. But by 2021 and 2022, people wanted care, people needed care, and we were losing opportunities to catch cancers and treat conditions. And so it was really the spring of 2022 where organizations like BC Healthcare Matters, the BC College of Family Physicians, and BC Family Doctors got together and said, there needs to be a different future in family medicine. And so that campaign that said everyone deserves a family doctor really started in the spring of 22. And it led to a rally or a gathering on the lawn of the legislature in May of 22, again, organized by the BC College of Family Physicians. And it was on that day where representations from Doctors of BC alongside BC Family Doctors and BC College of Family Physicians met with the then Premier and Minister of Health to say, we see what's going on here. We recognize there are patients who are constituents, who are people, citizens of British Columbia who want something different. And so it was sparked. LFP was sparked on that day with a commitment to say we need to create a different future for family medicine. And we started to meet, again, the Ministry of Health alongside Doctors of BC and BC Family Doctors, got to sit around the table for essentially every Tuesday from June of 22 and continues on to this day, trying to navigate the future. And so by October of that year, we had a framework of something that was going to look like the LFP. And then we were able to announce that February 1st, I believe, of 2023. And so it took, a fairly substantive amount of effort to change the entire system of primary care in about 8 months, which was rapidly fast. And I'll give great credit to the Ministry of Health, who had came to the table and said, this is our collective problem. How are we going to fix this problem? We don't have the same sense of what's going on in the office because you are the physicians in the office. The patients are unhappy. We need to do this different. And so again, it was a collective effort for many, many months that then got us to 2023. That has been now office-based LFP since, I guess, now 17, 18 months. And just recently, again, through the similar working group, there was expansion of the LFP into the hospital, into the maternity ward, and into our long-term care facilities. And so it continues to evolve to try and give patients access to the care that they need, the time that they need to have the services that they want, and the locations that they are, whether that be, again, in long-term care, in the hospital, on the maternity ward, or ultimately in the office where the vast majority of family physicians work.
I mean, I feel like that's really inspiring to hear that you were able to work with so many different folks and actually make such a large systemic change.
And again, I think it's Churchill that says, never let a crisis go to waste. For sure, that was one of our driving forces, was the current state was not acceptable for anybody, for physicians, for the government, for the association, and ultimately for the patients. And so we needed to do something different. And again, there are particular people, and I need to sort of give a shout out to Dr. Renee Fernandez, who is the now the Chief Medical Officer of BC Family Doctors, who was just such an important person to make that happen. But it wasn't one person alone. It was the Deputy Minister of Health, Stephen Brown, and the Assistant Deputy Ministers and representation from Doctors of BC. It was all of us in the room saying, we see our patients, we hear our constituents, we see what's going on, and we want a different future. And so it was commitment to work together. It was collaboration. It was, we aren't going to focus on all the problems, for which there are a multitude, but we're going to try and focus on the solutions. And I'm going to, reach out and talk with people. And I had the privilege early in the spring of 22 to sit down with Camille Curry, who's heavily involved in BC Healthcare Matters, to hear her story. And the people who have really advocated have been critical to influence the decision makers and those who get to sit in the negotiating room. And I think that's a continued ongoing privilege to engage with people, understand things, speak to listeners, speak to patients, speak to members of the public, so that we can have ongoing dialogue, we can best understand each other, and then hopefully make a change that is not only good for the province, but I think other provinces have looked now to BC to say, how did that happen, and how can Saskatchewan, PEI, Ontario, et cetera, adapt and move to the future as well?
It's really encouraging to hear how advocacy and collaboration can really make a difference. I know sometimes there's this apathy that can set in when we're like, oh, there's so many problems, but I really appreciate how solution focused that has been. And it's really paid off.
And I'll acknowledge that again, not um, that I'll acknowledge that collaboration is not easy.
Mhm.
And collaboration takes humility and it takes willingness to come to the table and sometimes yell and scream and sometimes just sit and listen. And so again, when you have a common goal and a common purpose of we need this system to be different and better, and we have millions of people having said so, that it's our responsibility to listen and to come to the table and sort it through. I think there are other provinces, even ones adjacent to us, where it's a much more adversarial relationship. And I think what we've demonstrated in British Columbia, and specifically through LFP, that it's a collaborative effort that makes it better. It's not the panacea. It's not the perfect thing. It's not the solution to everything, but it sure gets us a long way when we focus on the solutions and not the problems, and we start to create opportunities for us to fix those things together.
And do you have any statistics that you can share with us about what changes the LFP has provided?
Yeah, I can't say that I have the last week's data, but over the last several months, I think we're now up to over 80% of family physicians who are providing family medicine care are on the LFP model. And so, rough numbers, we have just over 4,000 physicians who are providing that care.
Mhm.
In the province, we have around 6,500 physicians. Some of those physicians are doing other things that are not necessarily family medicine directly. They're providing hospitalist care or they're providing emergency care exclusively. And some of the places in the province are not well suited to either fee for service or LFP. They are really in smaller communities and they're paid in a different model called APP. But generally, the ones who are in the community sizes, the medium to large communities providing LFP care, we have over 80% of the province doing that and have started to make some inroads as far as getting people attached to clinics, getting people access to the care that they need. And some of our larger centers like North Vancouver and Victoria are starting to see some growth and some people getting attached to care, which is really the whole driver behind this, was give people the time that they need, get them access to the care so that everyone deserves and gets to have access to family physician or family healthcare team.
So you mentioned the Doctors of BC and your association with them. Would you mind just telling me what drew you to work with them?
Yeah, and so the Doctors of BC is the association that sort of oversees the 17,000 physicians in this province. I get to be one of those physicians. And so 2021 is when I mentioned that there was crisis going on in 2021, that I think the healthcare system was struggling. We had gone from banging pots to lift up healthcare workers to protesting against urgent care centers and having a struggle with different accessibility to healthcare services. And so I had been in a transition point in my life at that time. And so I've said that I have always been a physician geographically and ideologically from hope. And so that became a place, a rallying cry for me personally. And so I put my name into the hat to become the president of the association. Prior to that, I'd been working with one of our collaborative committees called the Joint Standing Commission on Rural Health. And I'd been involved with divisions of family practice through the then General Practice Service Committee. So I had some agency or some connection through the association, but it was in late 21 when I sort of felt like, this would be an opportunity to serve through a challenging time. But if I can hopefully approach, me personally, these circumstances with some optimism and ultimately some hope, that we could move through. And so for 2022, as I mentioned before, able to be on the team that helped sort of start and negotiate the LFP. And then for 2023, served as a president of the association and had just an amazing time, traveling the province and connecting with physicians and meeting with different groups to help understand and advocate and support and listen and be the spokesperson for the doctors of British Columbia.
Great. So it sounds like you wear a lot of different hats. So would you mind telling us a little bit about your role as a program director at UBC?
Sure. And so after the year serving as Doctors of BC president, I had to navigate what next. And so then family medicine is near and dear to my heart from when I applied to medical school. And so an opportunity came to be the program director for the Department of Family Medicine. We call the postgraduate program. And so British Columbia is unique in that it's a fairly large province, geographically, with 5.5 million people. And we have a singular medical school institution for now. And so the UBC Department of Family Practice has 23 different cities that we train 204 family physicians per year, and that's the largest grouping of family physicians of any program in the country. And because we are so distributed, and so we have sites as far north as Fort St. John, as far south as Victoria, as far east into Trail and Castlegar, and a myriad of places in between. So I am the director. I get to direct what is 204 residents, family doctor residents per year, so about 400 in a 2-year cycle across 23 locations in the province. Again, urban, rural, remote, and everything in between. One of our great hallmarks is our Indigenous program. And so we have an Indigenous family medicine program over 2 sites in Vancouver, Victoria, and are really working hard alongside our Indigenous colleagues to try and both bring truth and reconciliation, but also how do we best serve a large portion of Indigenous people in BC. And so we have diversity, we have geographical spread, and we have the largest program in the country.
Wow. It sounds like a very, very diverse program that you run there. That's fantastic.
It's really interesting. We also have the largest intake of international medical graduates. So we have 52 international graduates a year that join our 204. And so both diversity from, you may have been from one of our rural communities or of our urban communities. You may also be from out of province, but you might also be out of country.
Mm-hmm.
And so again, we get to have all sorts of interesting conversations over the years about education and about, learning style and the Canadian healthcare system and the growth from when you were an undergrad student to a medical student to a resident and then to a later resident, and then you get to become a practicing physician. And I think medicine is one of those areas where we're constantly learning and growing, no matter what stage you're at. And I hope that it continues to build both confidence and humility with each of our residents, but ultimately with all of our practicing physicians.
Mm-hmm. Well, with having such a mix of in-province students as well as out-of-province and international students, I'm a bit curious to know what the numbers look like for retention. So are these doctors then staying in BC or where do they go afterwards?
And so our postgraduate program sort of monitors this over the last 20 years or so. And so I can fairly confidently say that if you are a UBC graduate from medical school and you come to our UBC residency program, that you have a 95% chance of staying in BC.
Oh, wow. That's really high. That's
really
great.
impressive. Yeah. And again, like, home is home, right? So if you're from anywhere in BC, but specifically, an area that you're able to train, it makes good sense that you're going to stick around because of your family and your partner and your connections, all those things. If someone's come from out of province, so they've come in from another province across the country, they went to medical school somewhere else, they still have about a 64% retention rate, which is still fairly impressive. People get drawn to BC after finishing medical school in Alberta or Ontario, Newfoundland, looking to explore the coast, looking for the BC lifestyle, mountains and trees and snowboard in the afternoon and sail at nighttime is not something you can do in other parts of this country. And so 65% is really good. And we're proud of that. We also recognize that people also want to return to their home, and the shortage of family physicians is not just in BC, of course, that it's across the country. And so recognize why people would come from out of province and then go back to where they're from. What I find interesting is that if the international medical graduates have also about a 90% retention rate. And so if they've come from another country, trained overseas, and have come into BC, they're 90% likely going to stay in BC for 3 to 5 to more years. And I find that really encouraging because, again, what it says is that we are trying to be a diverse and welcoming program, but ultimately trying to be a welcoming province. And so coming from a diverse background, from a multitude of countries across the planet, I think it makes good sense that if we make you feel like you welcome and you belong, that you will stay there. And I think that's been something that, as the program has grown from international medical graduates, from out of province graduates, but also our UBC graduates, that people want to be here, and we do our best to try and create those opportunities to help serve the patients of British Columbia.
It's really encouraging to hear that we have such a high retention rate and that people want to stay.
Hmm. We think that the LFPs helped encourage that, or at least some of our young
Hmm.
residents will say things like, "Oh, this has made a difference. This has made me want to stick around because it matters to my livelihood, to my sustainability, to my financial circumstance," because they've ended up with hundreds of thousands of student loans and trying to find a path forward in your early 20s or mid 20s or even early 30s. And so we think it's all come together at a good time.
I'm curious from a medical student perspective,
Hmm.
what are some of the reasons why students might pick other specialties over family medicine?
And so historically, there's been this sense there's some prestige attached to being a specialist. So, oh, I get to be a specialist, right? I'm obviously biased in my approach that I think family medicine is absolutely the best possible job because of the breadth and the opportunity to connect. But there was a sense, and specifically in our surgical specialties, where you would get paid more money to be doing a particular thing. So, for me to counsel you, you get some amount of money, but if I take your spleen out, you get a bunch more money. And so trying to think about, what is the training program, why people would be drawn in to do a surgical specialty or a specialty in general, I think gives everyone the opportunity to say, what I really want to do. I think the tide has been shifting in that regards, in part just because of the impetus and the need for family physicians, partly again because of the shifting system and sort of some lifting up of family physicians to say this is really important and we really need family physicians, and people want the kind of care and want to establish the relationship with family and physicians. And I think also just the program is trying to continue to evolve and say, what does it look like to have ultrasound in your family doctor office? So we can sort of look at that. How is virtual care intersect, or how can we now provide care again across the province? I mentioned yesterday I was providing service to some of our rural and remote communities via video conference. And so those sorts of things, as the program tries to evolve, how do we make family medicine the best possible way to serve the greatest number of patients, but how do we then lift up the people providing that care? And again, completely biasedly, I think family physicians are the most important element that we can provide in the healthcare system because they're the glue that holds all the system together, specifically when we have people situated and positioned across the province in places that they need it the most.
Do you feel like there's any strategies that could be implemented to make family medicine a more attractive field for students to get into?
I think I'll mention the driver of finances. I think as people walk out of medical school with $200,000 or $300,000 student loan, that's a big driver. And so again, the lift in pay has definitely helped assuage some of that apprehension. The lifestyle, and so the flexible lifestyle in family medicine is something that we currently highlight, but I think we could highlight a bit more. I could literally go a week where I spend some time in my office and some time in the hospital and some time on a boat on an outreach clinic and some time in virtual care, and I can work from home. I think that's something that people generationally are looking for, some more flexibility and some more autonomy. And that's something that we continue to highlight, but it's not until you sort of live and breathe it does it make a huge difference, where you say, oh, I can actually be fairly flexible. I'll speak for myself. I've had the privilege to work on 3 different continents, doing different outreach clinics. And so I think, medicine is more or less the same for people across the world, right? The system is different. And so continue to highlight that when you get trained well in British Columbia, there's no reason you can't go work in any other country in the world for the most part. And so whether you want to do humanitarian relief work or whether you want to go and serve for several months in a Ebola area, there's opportunities for you to go and learn those skills, constantly adapt. And I think people want passion and purpose to drive their work. They also need resources and finances to make that happen. And I think family medicine offers all of that. We just need to continue to highlight it in a good way.
I think those are all really great points.
Yeah.
Is there anything you'd like to say to our listeners who are considering a career in healthcare?
So I just believe with all of my heart that healthcare is something that will give you such joy. It's given me such joy and given such opportunity. And so I was speaking with a colleague recently who grew up in a small town in rural Saskatchewan, and she just said, like, I never imagined that I could do this. I just wasn't exposed to it. And so my big hope and my big message is, no matter where you live in this province, no matter where you live in this country, that there's a pathway and a place for you to be involved in healthcare. And that may be trained to be a lab tech, and that may be to learn to do ultrasound, that may be learn to be a neurosurgeon, But if coming to family medicine gives you the privilege to sort of be a medical student and walk alongside people and learn the craft of medicine, so learn the technology and the services, but then you get to care for people no matter where they are in their life, no matter where they are in the province, that's a privilege that everyone should try and pursue. And there's a multitude of ways to get there. No matter where you are, where you're from, and what you want to do, we have a place for you to be working in healthcare because it's only going to get more expansive over the years, and the patients and the population needs the care. And if you come with heart and mind and hands, that we will be more than happy to make spaces.
That's lovely to hear. And speaking from personal experience,
Mm,
being a healthcare worker
mm,
myself,
mhm,
is one of the places that I worked, we'd call it the second paycheck
mm,
because you get this gratification from helping people.
mhm.
And it's just not something that you can get in a lot of other industries. Because I tried, I got a little bit burnt out and I stepped out for a bit,
Yeah.
but it just wasn't as impactful. And I just came right back to healthcare because there is something just really special about being able to improve the lives of others.
Absolutely. My own journey was I was deciding whether I was going to go into pastoral ministry or healthcare, and that was sort of my journey back when I was doing some work in Africa in the 90s. And my recognition was, yeah, I can care for people in both of those fields. But the ability to provide something where I can go to any country, any province, any house, any hospital, any clinic, any community, and be welcomed in because of my skills opened up that privilege for me. And so it's been now 25 years of this profession, and exactly what you said, it can flex and move and adapt to my family lifestyle, and I have some ability to step back if I'm feeling a bit overwhelmed with a good group of colleagues, and I get to build in teams and navigate systems and put chest tubes and flush ears and shock people's hearts. And I was very honored a few years ago to be given the BC College of Family Physician and Family Doctor Award. And I made a comment in one of the interviews that there just aren't that many professions or opportunities in life where you can be there through birth and death and grief and sorrow and chaos and cure all on the same cycle. And that's absolutely the truth in healthcare.
Right. Congratulations on your award. That's
Mm.
fantastic. And I'm glad to hear that you have so much passion still after all of these years for this career. And it sounds like the learning never stops. And I think that's inspiring.
The learning and the humility never stop. And I
Mm.
think those are two important things where, I always say, like, I practice family medicine. It doesn't mean I perfected it, right? We're all in healthcare. We're all just practicing to make sure we do the best we can for the people that we care about.
Great. So I'm curious, in your opinion, what do you feel like are the most pressing challenges that we're facing in healthcare today?
For sure, across the province, and I would argue across the country, and maybe even the developed world, looking at how we get people access to the care that they need. The population is aging. That's not a surprise. I believe the statistics a few years ago were the largest growing population of people in the province were octogenarian women. And so that just means that you're more likely to turn 80 than you are to be born in this current cycle. And so it just means that as we are getting better and better about cure and diagnosis and heart disease and heart failure and cancer treatments, patients are living longer. And so we have a grain of our population, and we need to be sure that we're accommodating that and we're giving them the care and the time that they need and not being dismissive. At the same time is how do we then figure out how to provide more care to more people efficiently and effectively without having to double the size of the healthcare workers. And maybe that's what we need to do as well, but that's going to take some time to occur. And so now looking at how do we provide more efficient care, more effective care, and still giving people the time that they need. I think that's where the technology comes into play, right? And, many of my patients who live up the Fraser Canyon, we're just never going to spend 2 or 3 hours traveling down to go and see a specialist or a physician in an urban center. But if we started to use technology, we could close the kidney patient, the dialysis patient on virtual care with their nephrologist. Or now we're able to provide emergency services across the province. And so looking at the technology as one way, I think the other really important element is looking at how we embed teams into our services. And so over the years when I was working in Hope and part of the Chilliwack Division of Family Practice, we really built out a primary care network plan, which looks at how do we get people the care that they need. And so how do we embed nurses and pharmacists and mental health workers and even traditional healers from the Stolo Nation into our service. And so we're getting people the opportunity to get the care that they need in their home, in the place that they need. And how do we get the opportunity to then build the educational services wrapping around that? And that's really some of my driver right now is how do we get people who are learning family practice to embed into that team-based care? And people say they want to do it. They want to be involved. I want to be able to send my back pain patient to see the physical therapist first to get the treatments that they need before coming to sort of get their prescriptions. And so it's going to be an all hands on deck over the next several years. It's going to be continue to build more healthcare providers, which is why it's so important to get listeners involved and inspired to do so, but also then about how do we build really high functioning teams? How do we look at how to build a system where people get the services and the care that they need? How do we build technology as a part of that? And never have the technology supplant or replace the I care for you as a person or I care for you as my patient.
I think that's a really important point that you made there because we don't want to take that personal caring element out of the healthcare system.
And I think, again, not to belabor the LFP, but you get time. People want time to feel like you're being cared for, right? There are situations where I give news that I can't fix. You have a terminal illness or there's something going on that I can't actually fix. And if you don't spend the time, then people don't feel cared for, even if the outcome is the same. And so trying to build in time and using the technology to give people more time to get the care that they need, still acknowledging there's more and more people who need care. And so trying to find that balance and again, spreading out who gets to provide the care. How do we build those teams to be functional using technology, but again, making sure that people feel well cared for, that have someone that they can say, I know you, I see you, I understand you, and let's walk along this journey together.
It sounds like team-based care is really the direction we're heading in the future. What do you think would be some good strategies for implementing these multidisciplinary care systems?
So I'm always an opportunist. And so I think there are places where this is happening well already. And so leaning into those. And so although there was a rocky start to the urgent and primary care centers in this province, I think that's a place where there actually is the potential to have mental health workers and counselors and pharmacists and physicians and residents and medical students working alongside each other. I was very privileged to work at the Victoria one downtown for several years after I'd moved to Victoria a couple of years ago. And so under great leadership, and I'll give some credit to Dr. Paul Sawchuk, who has really led that clinic to really be not only an urgent care center, but a primary care center. I don't have to look very far across the province where there are communities that get involved and say, we want to be a part of this. And so Whistler 360 is a community initiative, really looking at how the community gets involved in provision of healthcare services and how social services and how food bank gets involved in looking after people who are in Whistler for a bunch of reasons. I visited Sycamore a few years ago where, again, they've been really engaged with the local pharmacy team and the local physician team and the municipalities helping to support all those bits and pieces. And so I think there are places where having people learn together, having people train together, having people understand what it is to be together is important. And then I'll go back to that humility piece. Physicians at times need to release some of those things that have traditionally been ours, and we need to let them go because we have a particular level of expertise or skill set that we need to be used to the best of our ability. But so do nurses and nurse practitioners and pharmacists and mental health workers and social workers and even traditional healers. One of my honors in my career is to sort of initiate one of the first hirings of a traditional healer in our clinic in Chilliwack through this primary care network. And so when one of our patients from the Stolo Nation wanted to come visit her, they could. And so really embed those in part of the team. And so the way to work together is to train together. The way to train together is to exist together. And again, in this virtual space, it doesn't mean we have to be in the same room all the time, but really looking at how we provide those care and services. And the last piece around, team-based care is looking to where are the opportunities to who else could be involved. And so the physician's assistants in BC have sort of had some signal that they could be a part of the team, and where they are focused, at least initially, is in rural emergency rooms. And so what a great opportunity to have a physician assistant who's been trained across this country, who's potentially, many of them have served in the military, have served in forward leading areas with doing trauma. And so great, let's get them involved in emergency services, specifically for our places that are struggling. Let's look at how we provide the care with the most hands on deck, if I could say that, with the most training possible. And then how do we get that to be the norm as opposed to a closure, or as opposed to no services available to remote, rural, indigenous, or just people who need care where they need it, where their home is.
Really appreciate your openness and your willingness to embrace change. And I know it can be hard to change models, especially, historically, if we've been doing something one way for so long. It's definitely hard to make those changes. But I feel like you make a lot of very valid points about how beneficial that is to share the load and to work together.
And I think, again, from my rural heart, and we've always done that in rural out of scarcity. Like we're doing CPR today, and so I need everyone to be involved because I can't do CPR by myself. We're going to work as a team. And I think what I've witnessed in the places that really function well is a commitment to each other, a commitment to the culture of caring, and a commitment to how we're going to look after this population. There are gaps in people accessing care in this province. Most of our really rural places say, well, there's not an attachment problem per se, because if you live in this small community, we're going to find a way to look after you. But if there aren't enough physicians or providers doing the work, then they quickly get burnt out. And so it's an interesting balance point between making sure we have the people in the community to be providing the services, to be providing the work. And we may need to incentivize that differently or create different opportunities to do that. But when we have really functional teams in rural communities, man, do they provide amazing service, whether it be office or highway trauma or difficult delivery of maternity services. And so there's just huge opportunity to learn about culture and connection and commitment to one another when we focus on our smaller places and ensuring that they get the opportunity to share and engage in those resources.
Wonderful. I think one of the best stories I've ever heard working in healthcare was from a nurse who would fly around in a helicopter to a lot of the northern territories and just assist the doctor in doing whatever they needed to do that day.
Yeah.
And so working with folks like that, like you said, it really increases that breadth of their scope and what they're able to do.
I was chatting with a nurse yesterday who's on a boat-in only community on the far side of Vancouver Island, and we were chatting about fishing and the whales and whatever else. But the nurses who work in outpost nurses, the physicians who are doing outreach clinics, I think those are the superheroes of the healthcare system because they're going to far off places. And I've had some of those privileges to do those kinds of things, but there's just a whole small group of unspoken physicians and nurses and even pharmacists who fly into amazing places to do great work. Last summer, I was able to go work in Masset up at the far end of the Haida Gwaii, and just a cool place, just an amazingly beautiful place, and seeing the physicians and the nurses sort of gather together and work together. And then some of them attended a ceremony on the beach in Old Masset where the Hawaiian boat was landing and being welcomed by the community. And so just such a richness of culture and connection and community that when we have the privilege as healthcare workers who practice generalist medicine to go and be in those communities and sort of be engaged in not only the care and the connection, but also the community itself is so amazing.
Mm-hmm. Absolutely. So I was wondering if you have any advice for our listeners who would like to advocate for more positive changes within the healthcare system. What do you think that they could do if listening to this right now is really inspiring them? What kind of actions could they take?
So I'll go from small steps to bigger steps. And so I think the first thing is gratitude. If you have a healthcare provider or if you have someone in healthcare services or your partner or child, it's just a bit of appreciation. And I think that's what warmed lots of our hearts as we navigated 2020 as people were banging their pots and saying thank you. We all recognize there's challenges in healthcare and people can't get everything they need at the time that they want it. That's a reality for physicians and nurses and pharmacists and patients alike. And so a bit of gratitude, I think, goes a long way. That's something that I'm continually working on and trying to be thankful for the people that I work alongside is to say thank you and be appreciative. And so that's a simple step. And even the medical office assistants who's trying to book your appointment for you, those are thankless jobs at times. And so when you can be kind and gracious and appreciative, that goes a long way. When it comes to real advocacy, and so I think looking at like, how do I say there's a problem, but how do I say it in a manner that says there's a problem and I want to be a part of the solution, right? Anyone can protest, right? Anyone can say, this is not okay, this is not okay, this is not okay. But I think the opportunity to say, this is not okay, and I want to act on it. And yes, we have a shared responsibility. And so the government, the provincial government, and even the federal government have a responsibility to provide healthcare. But also so do the communities and so do the individuals. And so trying to do things like volunteer and get involved with organizations like BC Healthcare Matters, but also volunteering downtown places like Kool-Aid, or just getting yourself involved to see what it is to be, in a difficult or vulnerable spot. And so advocacy can absolutely be website and media and that kind of stuff, but it also can be you willingness to go and walk alongside, go volunteer with the Red Cross or do something where you are making a positive impact. And it's amazing how your mind shifts where you feel like you're empowered to do something and be involved with part of the solution. And then finally, on a large scale advocacy, and again, aligning with organizations like BC Healthcare Matters. As a physician, again, the BC College of Family Physicians are really some of our great advocacy groups. And so speaking into them to say, I'm a member of this organization or I'm a member of the public and I want to get involved, and speaking again with some sense of not this is all terrible, because there are places that it is terrible, but here's how we can be a part of the solution. And so here's how we think that there's an opportunity, and then listening intently for others to then have those same ideas. Because I have sat around many a boardroom table with an idea, recognizing that I am not the smartest person in the room. And I need to be listening to the Camille Curries, the Darren Jonasons, the Renee Fernandez of the world who have better ideas than me. And so approaching the advocacy with a level of humility to say, we are about caring for one another. We are about caring for the healthcare system. And there is no healthcare without care. And so really trying to advocate for that mentality, that approach, and then getting involved with organizations and entities who believe that and are prepared to walk that walk.
I really appreciate how solution focused you are. I think it's a lot easier to point out problems than it is to actually craft solutions for them. And I think you're right. It's really important to work together, and volunteering really is a two-way street. It's mutually beneficial for everyone. So,
yep.
I want to thank you so much for all of your valuable insights today and all of your hard work and advocacy. We really appreciate it. So thank you so much for joining us on the show.
Thank you, Jenna. It's a pleasure to be here, and thanks for the work that you do as well.
My pleasure. Remember, together we can advocate for the health care that we all need. Thank you for listening. The content provided on Your Healthcare Matters is for informational purposes only and is not intended as medical advice. Always consult with a qualified healthcare professional regarding any medical concerns. The opinions expressed by guests are their own and do not necessarily reflect the views of the podcast or host.